In this capture, we're going to look at musculoskeletal assessment, diagnostics, and care modalities. Now, this particular recording is going to be a little bit longer than usual just because of the amount of content that is in the chapter. So we're going to start with a brief review of anatomy and physiology. Functions of the musculoskeletal system, obviously it protects vital organs. It gives us that skeleton, that cage. So it's the framework that supports body structures and mobility. It helps us be able to move. It produces heat and helps maintain body temperature. And it helps facilitate the return of blood to the heart. Think about when your patient's walking post-op and ambulation and the contraction and the contraction of the muscles and movement of the bone. That's what helps promote venous return. It's also a reservoir for immature blood cells, and we'll talk about that more in the capture for class 4. And it's also a reservoir for vital minerals. So just some basic facts. You have 206 bones in the body. We have long bones, short bones, flat bones, irregular bones, and then of course we have the joints and muscles. So again, you don't need to know the in-depth that you needed to know for anatomy and physiology, but you do need to have a basic understanding of the musculoskeletal system, what's there, and how it works. So going back to bone formation and maintenance, the process of bone formation is known as osteogenesis. And osteoblasts are the cells that form bone, and osteoclasts are the ones that destroy or resorb and remodel bone. So when you think about a normal, healthy person, you have osteoblasts being equal to osteoclasts, and everything is nice and clean, and everything's going well. When you have diseases like osteoporosis, which we'll talk about later in this unit, you see more osteoclast activity than osteoblast, hence you have demineralization. So things that regulate this, stress and weight bearing. Okay, so we'll talk about how walking, weight bearing exercises such as walking is a very good prevention strategy for bone disease. Vitamin D as well as calcium, parathyroid hormone and calcitonin, and of course one's blood supply. So thinking about what happens if there's an injury to a bone, such as a fracture. A hematoma is going to form 1 to 2 days after the fracture. In stage 2, you're starting to see some fibroblasts and osteoblasts migrate to the fracture site, and they're starting to make some fibrous tissue, callus formation, trying to get things starting to heal. In stage 3, you have the bony callus formation, and ossification begins during the 3rd or 4th week. And then when you finally get to remodeling, this is where the osteoclasts now remove the necrotic bone, and you're getting healthy bone again. Looking at joints, we do have several joint types. We have the ball and socket joints. You have your hinge joints, your saddle, pivot, and gliding. So just kind of thinking around the synovial cavity, that's the cavity between the joints, and that's the area that has the lubricating and shock absorbing synovial fluid. And also cartilage. Other structures, we have the ligaments, the tendons, and the bursa sac. So as we start talking about different disorders, we're going to see some different aspects involved in that. Muscles are attached to the bones and structures by tendons. Muscles are encased in fascia, and the contraction occurs via electrical stimulation. So when we're thinking about assessing muscle tone, we typically will describe that as either flaccid, spastic, so you have kind of spasms, and atonic, which is a normal bone. Things to keep in mind, Mama always said, if you don't use it, you're going to lose it. And that is very true for your muscles, because you have to be using your muscles, even at a basic level of simply walking, in order to keep them functioning and keep them in use. You can get hypertrophy where you get enlarged muscles, or you can get atrophy where the muscles actually waste, particularly from disuse. So looking at assessment, and as a nurse, assessment is the first part of the nursing process, so we're always focusing on that. Thinking about health history, you want to know what's in their past medical history, past surgical history. How are they doing with their ADLs, their IADLs? How is their problem really affecting their everyday functioning? And you also want to know about their meds. As we get farther on in the unit, we're going to talk about certain medications that are used to treat specific conditions, but we're also going to talk about medications that, as side effects, may predispose patients to certain conditions. Okay, if you want to tie this back to Unit 2, when we talked about the fluoroquinolones and ciprofloxacin, that those patients were at higher risk for tendon rupture, particularly the Achilles tendon rupture. So that's just one example. There are other medications that may put patients at risk for different musculoskeletal problems. In looking at the focused assessment, one of the first things we really want to pay attention to is height. When patients go for their annual checkup, their annual physical, one of the things they always do is measure height. And we do that because as people get older, they're more susceptible to what we call compression fractures or vertebral fractures. And if they're having those, their height will actually decrease. So it's very important to be measuring their height periodically and trending that data. Looking at the posture is also very important, and you can see that in the picture on your screen. Looking at a normal posture, you do have some slight curvature of the spine, but with kyphosis, that is essentially, the non-technical term is kind of a humpback. Lordosis, you tend to see an exaggerated inward curve of the lower spine. You see this a lot in pregnant women, especially as they're carrying closer to term. And then, of course, scoliosis, where the spine, instead of it being nice straight down the middle, when you're looking at a patient posteriorly, that spine is kind of curved. It has some S curve in there. And you can also note and see it in the picture, somebody with scoliosis especially, their shoulders are not going to be at even height. So you really want to pay attention to their posture and look at their spine. Okay. With neurovascular status, we're going to kind of talk a little bit about that on the next slide. But basically with musculoskeletal, we talk about the trunk, but we're also talking about the extremities. So with neurovascular status, we're looking to make sure that those extremities have movement, sensation, and circulation. So continuing on with the focused assessment, you want to note their ambulation ability. Are they independent? Do they require an assist? Is it a 1 assist, 2 assist, maximum assist? Are they using some sort of assisted device, a walker, a cane, and what type? So you want to be specific. Looking at their gait, is it steady? Is it unsteady? Do they have a shuffled gait? Is it very slow? You want to be able to describe that. In relation to the extremities and the joints, the abbreviation MAE refers to moves all extremities. And for our purposes in clinical, that is a really good thing to be able to document MAE. If you're writing full ROM, remember, ROM is range of motion. So if you're writing full ROM, that means that you have assessed every single one of those joints, and every single one of their joints is at maximum function. The reality is we don't assess that when we're in the hospital. We do not assess every single joint. So it's more appropriate for us to document MAE and then note any limitations in specific joints that you might note on assessment. Okay. Make sure you are addressing all of the extremities, UE upper extremity, LE lower extremity, and make sure you're using right and left as your qualifier. Back to what we talked about a couple seconds ago on the last slide, talking about neurovascular status. And we want to make sure that the patient has movement, sensation, and circulation on all of the extremities. We do this through neurovascular checks. And as you look at patients' charts, you might see they're ordered neurovascular checks. So basically what that means is we are assessing the limbs for temperature, and not temperature in the sense that we're using a thermometer, but does the temperature of the extremity feel warm? Is it cool? Is it cold? Is it really hot? We're assessing pulses, typically the most distal pulses. So upper extremities, we're talking about the radial pulses. Lower extremities, we're talking about the pedal pulses and potentially the posterior tibial pulses. Capillary refill on all the extremities, Should be immediate to less than 3 seconds. That is considered a normal finding. If it's longer than that, it's considered delayed. We want to look for their ability to move that extremity. Again, can they move it? Is there limited movement? Do they have sensation? Can you feel that, or can they feel you touching them and identify where you're touching them? And then, of course, the presence of pain. Are they having any pain and discomfort in the particular extremities? What is the level of the pain? What does that pain feel like? Are they not feeling any pain at all? Are they not feeling any sensation at all? I also want to mention the term paresthesia. So any numbness, any tingling, you want to be assessing for with neurovascular checks. For strength, you want to make sure you are assessing each of the extremities, and you want to specify the extremity when you're documenting. The muscle strength scale that's on the screen, this is right out of your foundations text, okay? So you really, if you're in clinical, you really should be assessing their muscle strength based on this scale. So that's something you should be practicing every week in clinical. There is a difference between the ability to move and an extremity strength. Okay, so make sure you are addressing and documenting both. Some tips for documentation. This actually comes right out of the ATI skills modules, the ambulation, transferring, and range of motion, as well as the physical assessment of the adult. Some things to kind of note with ambulation: how far did they ambulate? How much assistance did they require? Do they have any devices? And of course, any teaching done. Same thing with transferring. How are they transferring? What type of transfer was performed? Range of motion, we kind of talked about that. Was it active range of motion where the patient was doing it with instruction, or was it passive, what you were doing? Also, how many repetitions did you do with what specific joints? In relation to positioning, that's also really important too. How many people does it take to transfer and position a patient? Are we using anything special like a footboard? Are we using hand rolls? Are we using trochanter rolls? Do they have any special devices like an abductor pillow? Those are things that you want to note and make sure you're documenting. So moving on to diagnostic tests, and there are quite a bit with this unit, okay? X-rays are pretty explanatory. Those are just a single view, looking at the actual bones. You can do multiple views, take them from different angles. They might do them repeatedly, like serially, to evaluate healing of a particular bone. It might show us something about joint fluid, joint spacing if it's narrowing, any type of spur formation. Not really a whole lot of prep for x-rays, just simply, making sure obviously they are not pregnant, because radiation can cause damage to the developing fetus. They do use radiation precautions in the sense that they put the vest over the patient to kind of cover the thyroid. They should be using the thyroid flap on the vest, and as well as covering the reproductive organs, because those tend to be the most susceptible to radiation. And arthrography, that is just simply an x-ray that is taken with joint movement. A lot of times that does use some contrast to be able to show and just act as a contrast so you're able to see what you're really looking for. But basically that's an x-ray of a joint in movement. Ultrasound, that's often done to look at specific joints to see if there's effusions, potentially blood clots in the leg. Not really a whole lot of prep for that. It's just, the goop on the leg, using the probe. It can be a little bit uncomfortable with the pressure of them pressing the probe against it for your patient, but from a nursing perspective, there's really not a whole lot that we need to do with that. The CT scan, we've talked about this before in previous units. It may be done with contrast or without contrast. If your patient is receiving IV contrast, very important to verify allergies. We're looking for iodine, betadine, shellfish. Also very important to check their kidney function, because that dye does get metabolized through the kidneys. So looking at that, pushing fluids afterwards. MRI, Obviously, that uses a magnet, so patients with metal implants, clips, or pacemakers absolutely cannot have an MRI at all. Any type of metal needs to be removed from the body. Hearing aids, jewelry, credit cards, cochlear implants, transdermal patches, if they have a nicotine patch, a nitro patch, anything like that, those need to come off prior to an MRI. Certain MRIs do use a contrast. That can be toxic to the body as well. So really checking those labs, checking allergies, and really pushing fluids afterwards to try to flush that stuff out of the system. Biopsy, this really is where they're taking a sample of fluid or they're taking a sample of bone. A lot of times it's the bone. They can do a muscle biopsy as well, where they're looking to see the condition of the cells. Many times they're looking for malignancy. Other times they're looking for other particular disorders. Post-operatively, just important to watch the site for bleeding. It's going to be swollen, so we'll elevate that, ice or cold to the area, analgesics, and just really watching for signs of infection and pain management. Some lab studies that we can do, and this is all just blood work, okay? We can run a serum calcium level. That's pretty important. We can look at phosphorus. And calcium and phosphorus are inversely related. So if calcium is low, phosphorus is going to be high. If phosphorus is high, calcium is going to be low. We can look at thyroid labs because, again, the parathyroid hormone and the calcitonin help regulate bone growth and bone function. We can look at calcium in the urine to see that if the kidneys are putting out excessive calcium, that can indicate a problem. And we can also look at very specific bone formation markers. Usually they're looking at that if they're suspecting some sort of malignancy. Additional diagnostic testing, you have the nuclear scan or the bone scan. This is really used to detect very small fractures or diseases of the bone. So basically a radioactive isotope is injected and you wait a little bit so that isotope can get circulated through the body, and then they'll go ahead and do the scanning. The scan itself takes about a half an hour to 40 minutes, and the patient really needs to lay still. You're going to get the best picture if they're laying still. And depending on the test, if it's a true bone scan, they may repeat the scan at specific intervals, sometimes 24, 48, and 72 hours. Just to see how the scans have changed so they can identify problems. The dual energy X-ray absorptiometry, the DEXA scan, this is used to estimate the density of bone mass and the presence or extent of osteoporosis. So this is actually a screening test that's done in females who are 65 and older and men who are 70 and older. Basically, the client lays on an X-ray table, there's no contrast material, and they will scan them, and basically they're going to get a score. And depending on what their score is, it will determine if they are a healthy bone, if they have osteomalacia, which is where you're starting to see the destruction of bone, or full-fledged osteoporosis. And we'll talk more when we get to the class on osteoporosis about that. Your EMG and your nerve conduction studies, they kind of go hand in hand. Basically, little either electrodes or needle electrodes are inserted into the muscles, and different electrical activity is put through those sensors, and it's recording the muscle responses. So basically, it's looking for muscle weakness, inability for muscle contraction, that sort of thing. Very important as a nurse to know if your patient's taking anticoagulant medications. Really, with any of these that are going to involve an actual injection into the bone or an injection or electrode into muscles, because your patient's going to be at risk for bleeding. We do want to teach our patients, if they're having that particular study done, they should not be putting cream or lotion on that day. They should avoid caffeine because that can interfere with the test results. And they're going to feel some pain and discomfort with these. I personally have never had one, but patients describe them as being extremely uncomfortable. So you need to tell them that. They need to expect that. They may also have some bruising afterwards. We want to teach them to watch that site because it can get swollen, tender. We want to watch for signs of infection. They can use elevation, they can use compression like warm compresses, or they can even use ice at the site as well. Arthrocentesis is where they're actually aspirating some fluid from the joint space. And that fluid should look clear, pale, and like a straw color. And there really should not be a whole lot of it if they're aspirating. Arthroscopy is a natural surgical procedure where they're making tiny little incisions. They're going to actually go in through those incisions with a scope that has a camera on the end of it and be able to see inside the joint. Many times they can also do some surgical repairs with arthroscopy. It depends on if it's a diagnostic or this is actually an interventional arthroscopy. Again, just thinking about post-op, we've made incisions, putting stuff in there, so we're always going to be concerned about risk for infection, teaching them to watch for that. Post-arthroscopy, there's generally a splint, or if we're talking the elbow, it would be a sling. The extremity should be iced and elevated for 24 hours. Of course, teaching the patient how to do their own neurovascular checks. What do they need to be watching for? What is normal? What indicates that there could be a problem that they need to call the provider? So now we're going to switch to some care modalities and just kind of hit the highlights of these because you may be using them as part of your clinical practice. So sprints and slings, from splints, they are contoured plaster or they're some sort of pliable thermoplastic material. These are for situations that do not require rigid immobilization. What's nice about them is they do allow for anticipated swelling, whereas if I put a cast on right away and that extremity swells, literally that swelling has no place to go. Splints and slings are removable, so they do allow for special skin care. So again, if we can use something like that based on the patient's situation, they can be very helpful. Now, braces are a little bit different, okay? True braces are custom fitted to the body, and they do provide support, they help control movement, and the whole idea with these is to prevent any additional injury. So typically these are going to be things like knee braces. You may see back braces for patients that have scoliosis, that sort of thing. Looking at casts, and I just kind of mentioned these beforehand, these are when you do need a rigid external immobilization device. Years ago, we used to just make them out of fiberglass. That took forever because it took forever for the fiberglass to dry, almost up to 3 days for it to completely dry. Now, a lot of times we're using plaster of Paris, which dries in about 45 minutes to an hour. But we are also seeing some of the other ones, and you can see an example of the one at the bottom that's over the wrist and the lower forearm. These are some of the new 3D printed and things like that that really do allow for visualization underneath the immobilizing device. So the whole point of this immobilization, basically, we'll talk about fractures moving forward, but when there's a break in the bone, they're going to do what they call a reduction. So the reduction is about getting the bones back in place, correctly aligned. And once that happens, we need to put an immobilizing device on to keep it in place so the bones can do their own thing. Your body can do its own thing and actually heal the bone and get everything back together. This is helpful for correcting deformities, and it gives uniform pressure to all the soft tissues, supporting and stabilizing those weakened joints. Now, how long a cast stays on really depends on the patient. It has to do with how quickly that bone is going to heal. Typically in our younger population, our kids, those bones tend to heal pretty quickly. Older adults, it might take a little bit longer. So when you're taking care of somebody with a musculoskeletal device, before you get the device on, we need to treat any type of lacerations, abrasions, anything like that. You certainly want to tell them why you're putting it on and what the procedure is going to feel like. The casting material as they're putting it on, it's wet, so they don't really want to be touching it because you can put indentations in it, and it's just kind of messy. You want to address pain management. You have to assess their pain. Where does it hurt? What does that pain feel like? What is the intensity? And consider both non-pharmacological and pharmacological management. A lot of times we're using a combination of both. The real key priority I want you to be familiar with is you need to watch neurovascular status, both before we do the reduction, after we do the reduction, before we put the immobilizing device on, after we put the immobilizing device on. And we call it the 6 Ps. I kind of mentioned these a little bit before when we were talking about neurovascular assessment, but things that you want to keep in mind. Pain. If your patient is having pain that is unrelieved by their pain medication and it's getting worse, that's a big red flag. Poikiloothermia, just a real fancy word for looking at the temperature of the limb. If it's getting cooler, if it's cold, especially in comparison to the non-affected extremity, that's a red flag. Pallor refers to the color, where the color is starting to get pale. It might even be getting a little bit cyanotic, bluish, grayish. Again, compare it to the unaffected extremity. Pulselessness, if you start feeling diminished strength in those peripheral pulses or not being able to assess the pulse at all. First things first, get a Doppler. Is that pulse still there with the Doppler that you just can't feel, or is it completely gone? Again, compare it to the unaffected extremity. Are they experiencing paresthesias, numbness, tingling, shooting pains? And what is their ability to move? Can they move that extremity? Can they move that foot? Can they move those toes? Or are they having decreased movement? Again, make sure you are comparing it to the unaffected extremity. But if you're seeing those things, you're seeing changes in what they were previously, that is a big red flag. You need to notify the provider immediately. You also want to consider the impact of the injury to the patient's physiological functioning. How is this going to affect their ADLs or IDLs? Not to be kind of graphic, most of us are right-handed, okay? So I want you to kind of think for a moment, if you broke your right wrist and you were in a cast and you have to wipe your bottom after you go to the bathroom. Be a little hard. Not that you can't do it, you can learn the other way, but you need to consider the impact of the injury to their everyday functioning. Is this going to affect their ability to drive? Is it going to affect their ability to walk, to, write, to type? You really want to consider that. You want to talk to them about activity and exercise and balancing that with rest, not overdoing it. Certainly medications, particularly in relation to pain management, and really reinforcing to them that medication is prescribed and recommended based upon what is expected to control their pain. They're not going to be pain-free, and it's very important for them to understand that. But if we can manage their pain that they're staying at a 1, a 2, a 3 at the most, that's where we want them, okay? But if they're taking their medications as prescribed and their pain is still 6, 7, 8, 9, 10, and it is not being relieved with that, that is a red flag. They need to call the provider. They need to know how to control swelling by using elevation. Again, as I've been kind of harping on, reportable signs and symptoms, what things would prompt them to call the provider, what things are emergent that would prompt them to go immediately to the ER. And also talking to them a little bit about cast removal and then aftercare. It is not uncommon after the cast is removed for the muscle underneath to be atrophied. Okay, it hasn't been used in a period of time. So they need to restart with, range of motion exercises, some strengthening exercises, some physical therapy to get that back up to maximum functioning. We also need to teach them how to take care of minor skin irritations. Casts, braces, anything like that, especially on the edges, they can be irritating to the skin. So you might need to pad those edges either with a tape, or moleskin works really well. Sometimes they'll be itching inside the cast, and it's so awful because the cast is there and you can't scratch. It itches and you can't scratch. So what they have found, if you use a hairdryer on cool setting, very important, cool setting, and kind of blow it down there inside the cast. That kind of helps relieve the itching. But you need to tell them absolutely never, ever, ever stick any foreign objects into the cast. I will never forget during my pediatric rotation, I was in the clinic and we were removing a kid's cast, and it was a leg cast. It was like a lower leg cast. It was an ankle fracture or something like that. And they took the cast off. They bivalved the cast and they were taking it off. And all of a sudden we saw this purple streak, and we're freaking out, of course, at first sight, thinking, oh my gosh, did he develop some sort of circulatory problem, anything like that? Here it was a purple crayon that was laying inside the cast, because the kid was itching and he tried to scratch with the crayon and it fell inside the cast, and of course he didn't tell anybody. So make sure you tell them not to stick foreign objects inside the cast. Compartment syndrome. You need to teach your patients not necessarily the term compartment syndrome, but what to look for. Because remember I mentioned before that your braces and your splints, they allow for room to swell. The cast does not. So if you have an injury, and it may not even involve a cast, if you have an injury where there is damage to the muscle, you can have swelling of that muscle, and because it's encased in the fascia, the muscle has nowhere to swell. Same thing can happen with a cast. The extremity is swelling, there is no place to go. What I want you to understand about this is when it can't swell out, it pushes back in on itself, which means it's going to impair circulation, it's going to impair nerve transmission. And bottom line, damage will start happening within 4 to 6 hours. And if we don't do something very quickly, that tissue is going to become necrosed and there will be permanent injury. And I have seen situations where that has resulted in the loss of a limb. So looking at the assessment findings, okay, again, things that I mentioned before: pain unrelieved by opioids and elevation, pain with or increased with range of motion. That is a classic sign. Paresthesia, so numbness, tingling, pallor, cyanosis, poikilothermia, cold extremity, and diminished pulses. The muscle will often feel swollen and hard, and if they're doing internal pressure measurements, it's going to be above 8 millimeters of mercury. This is something that needs immediate notification to the physician. Okay, remember how a lot of times I say there's things that you can do first, additional assessments that you can get, some interventions you can try first. This compartment syndrome is something that you need to address and jump on immediately. The provider needs to know. Because what's going to happen is you're going to keep the extremity at a heart level, you're going to loosen any bandages or tape, but basically the provider is going to come in and they're going to have to bivalve that cast. The cast is going to have to come off. In severe cases, or when it's not a cast issue and it's a muscle issue, they may actually have to cut into the muscle to open it up and to relieve that pressure. And that's what you're seeing in that picture to the right side of your screen. That's a fasciotomy. So those wounds, they're open wounds. They're going to stay open for a couple days. Again, all aimed at relieving that built up pressure. But if we don't, they can lose functioning and perhaps even physically lose their limb. For external fixation devices, these are used when we cannot get the bones in alignment and immobilized with a cast. So these are often used for open fractures if there's soft tissue damage or things are really complicated. Basically, it is external hardware that has screws and pins and rods that are going into the bone, and there's this external fixator that's keeping them in alignment, intact. Okay, so the discomfort is actually pretty minimal. It's more an anxiety, fear, a shock, a just freaking out of seeing the device like just coming out of your leg or your arm. This generally does allow early mobility, although you need to be careful with the device that you're not banging it around. Very important to elevate the extremity because we want to reduce edema. Again, monitoring for signs and symptoms of complications. So those neurovascular checks, okay, if you learn nothing else from this capture, please, please, please know the neurovascular checks. How do you assess them? What are you looking for? What's normal? What indicates a problem? And what do you need to do? There's going to be pin care related to this, which we'll talk about, because you actually have the device that's going into the skin, into the bone. So you have portal of entry, potential risk for infection. And patient ed is pretty important with this. So speaking of pin care, that gets done every shift and as needed. And there's two purposes. One, we're monitoring for signs and symptoms of infection. And two, we're trying to reduce the risk for infection. Okay? So assessment-wise, you're looking for the same stuff you'd be looking for an IV. Redness, swelling, warmth, drainage. If there's drainage, you want to note the color, amount, and odor. Now, it is expected there's going to be some clear fluid for the first 48 to 72 hours. That's just part of the normal inflammatory insertion process. You want to pay attention if the pins are loosening at all, or if you have, there's a typo there, it should be tenting, T-E-N-T-I-N-G, tenting of skin at the pin site where the skin seems to be growing up around it. You're also going to clean around the pins, and we're going to use a substance called chlorhexidine. It's going to be 1 cotton swab per pin, and you're going around in a circular motion, kind of similar to how you would clean the male genitalia if you were doing a urinary catheter. With traction, traction involves pulling force that promotes and maintains alignment of the injury. It's used for a lot of things. It helps reduce muscle spasms and pain, but the main purpose is to realign the bone fragments. Okay, so this is really important. We got to be in alignment, realign everything so your body can begin the healing process properly. If bones are not aligned properly, the healing process is going to start, okay, regardless of whether they're aligned or not. And what happens is you'll get a poor healing of a fracture that is going to result in long-term complications if you don't have them aligned. So that alignment should also help correct deformities, and realigning should help minimize or prevent soft tissue injury. It's important to understand that traction is generally a short-term intervention that is used until other modalities are possible. And when the provider writes the prescription for traction, it's going to include the type, it'll include the amount of weight, and it will also include parameters that if the traction can be removed for nursing care. You know, when we have to reposition the patient, can we remove the traction? Can we not? Again, because it's the opposing pulling forces, counterforce must be applied. So in some cases, it's the patient's own body weight and position in the bed that provides the counterforce. And you can see some pictures on the screen of different types of traction, where you can see the weights hanging off the end of the bed or off the head of the bed. That's helping to provide the counterforce. Okay, if your patient has skeletal traction, that is never interrupted. Okay, so weights are not removed unless intermittent traction is prescribed. So that's going to be in that original provider order. And you need to be very careful as you're working around the bed, because you don't want to reduce any of the pull. You don't want to jar the weights. Everything should be unobstructed. The weight should hang freely. If they're using knots or a foot plate, it should not touch the foot of the bed. Okay, it's very, very important. So as a nurse, you're going to be checking the traction device, and you're going to be maintaining body alignment. That's going to be a priority for you. In most cases, we'll be using a trapeze above the bed that the patient can reach up and hold on to. That's to help with moving in the bed. We will have to shift their position regularly because they have diminished mobility. They're going to be at risk for skin breakdown. So using pressure reducing mattresses or devices is very important. If there's any type of pins, and more so I'm thinking like the halo traction here, pin care is going to be used for that as well. They should be taught to do foot and leg exercises every hour, as well as some minor passive exercises to maintain muscle tone and strength. Because of their immobility, they're going to be at high risk for the development of blood clots, so we're going to use VTE prophylaxis. Most of the time that's going to be in the form of subcutaneous Lovenox or possibly sub-Q heparin. Very important that you're monitoring for complications of skin breakdown, nerve damage and circulatory impairment. It goes back to those neurovascular checks. Psychosocially, this can make your patient very anxious, so we want to try to help them with that, and we want to promote self-care as much as possible. A CPM device, and we're not actually seeing these as much anymore, but I did want to put it in here just in case you would happen to run into one at clinical or in your future practice. They're called continuous passive motion devices, and they're used to exercise a joint and really post-surgery to try to prevent scar tissue. So in the past, you've pretty much seen these used with knees, that they would use them on post-op knee replacements to keep the joint somewhat movable and try to prevent that scar tissue. So whether or not it's in use is going to depend on the surgeon preference. What we're seeing now instead of the CPMs is really early and frequent ambulation with range of motion exercises and PTOT. I personally have not seen a CPM device used in several years. It's really going to be a surgeon preference. If you are using them, very important that alignment needs to be accurate within the device, okay? Now, the device settings, how much it's going to flex, how often, and the duration of the treatment, that is all going to be in the actual provider order. So it's very important that you look at that just the way you look at an IV order. What's supposed to be running? What's the rate? How long is it supposed to be going? You're looking at that prescription. Okay, so we've kind of gone through the devices, and for this capture, I threw in arthroplasty as well. So arthroplasty is just a replacement, a surgical removal of a joint and replacement either with a metal or plastic prosthesis. And the reason I threw that in here is because it kind of hits to post-operative musculoskeletal care. Okay. Reasons for an arthroplasty, most of the time it's going to be osteoarthritis. Most of your patients have a history of moderate to severe osteoarthritis with unmanageable pain and really serious interference with their ADLs. Other reasons you might see it, osteonecrosis, sometimes rheumatoid arthritis, of course trauma. If they can't fix what's already there, they may just elect to take it out and put an artificial joint in, and also congenital problems. The thing you have to keep in mind with arthroplasty is you are putting in a complete artificial joint. And bones and joint spaces are not highly vascular to begin with. So what that means is if an infection gets in there, it's very, very, very difficult to treat. So preoperatively, these patients are screened for active infections or recent infections. And they will literally cancel this elective surgery and reschedule it if the patient is showing any type of sign of infection. You also want to consider comorbid conditions, things that are going to increase the patient's risk of complications. So diabetes, hypertension are the top two, osteoporosis because they already have weak and brittle bones, and any type of respiratory or cardiac conditions. Those are all going to increase the risk of complication and even potential death to the patient. Pre-op labs are typically going to involve a CBC, a BMP, a urinalysis, chest x-ray, and EKG. Because there is the risk of blood loss during this surgery, if the patient is anemic, they may consider using epoetin alpha, which will help stimulate the bones to produce more red blood cells, or the patient may elect to donate their own blood to receive it back during surgery as needed. Preoperatively, we're going to make sure we educate the client on what to expect postoperatively in relation to physical therapy, in relation to exercises, getting up the same day or the next morning. And they're also going to be taught about a surgical site scrub with chlorhexidine. Many times these patients are given a special soap to shower with the day before. They are instructed to sleep on completely clean sheets the night before surgery and to do a shower with that special soap again in the morning. Very important when you're using the surgical site scrub stuff. That should be over their regular body skin. They should not be scrubbing their genitalia with the chlorhexidine. You can actually cause some pretty serious problems with that. Intraoperatively, most of the time it's going to be either general anesthesia or more likely you're seeing spinal anesthesia along with nerve blocks. During the surgery, the components are typically cemented into place. If they're cemented, the patient will be able to weight bear as tolerated. If they're not able to cement and they just kind of put them in there and stabilize, the body's own bone will grow into those areas and eventually stabilize it. If that's the case, they may be non-weight bearing on that extremity. So it's very important that you check the provider's orders post-operatively as to weight bearing status. If you see WBAT, that's weight bearing as tolerated. So then they are permitted to bear weight on that extremity. So just pay attention to that. And generally, prophylactic antibiotics are started 30 minutes before the surgical incision is made, and they typically get 3 doses post-operatively. It all ends in the first 24 hours. Initially, coming out of surgery, the focus is going to be the ABCs: airway, breathing, circulation. From a circulation perspective, we're looking at general circulation, but also limb circulation, those neurovascular assessments. We're looking at vital signs, and they will often repeat the labs, specifically the hemoglobin and hematocrit, to check against their preoperative labs in evaluating blood loss. Pain management is going to be important. In PACU, if they've had spinal anesthesia and a nerve block, they're probably not going to be feeling a whole lot of pain. There might be surgical drains put in place. Those typically stay in place for 24 to 48 hours. As nurses, we're responsible for assessing and emptying those drains, looking at the site to assess the site, and caring for the site. Again, you're going to use sterile technique to clean around the insertion site of the drain. Certain drains may have the ability, what they call an auto cell saver, where they collect the blood that's coming out, and depending on certain circumstances and the hospital protocol, we may be able to infuse that blood back directly into the patient. Other post-op care, just general things, mobility and ambulation, we want to get them out of bed to the chair, at the very least dangling on the side of the bed. And depending on the time of their surgery, sometimes that is literally done the evening of surgery. If not, it's definitely done post-op day 1. They're out of bed to the chair. We start getting them up and walking post-op day 1. Again, weight bearing is tolerated. Physical therapy is going to be involved. Looking at assistive devices, most of them will use a rolling walker at first, and the focus is on strength, range of motion, and safety. Neurovascular status, extremely important. Once we get past that initial post-op period, we're looking at assessing every 2 to 4 hours, again, comparing to the other extremity. Our other big push is going to be preventing infections. So good hand washing, aseptic technique with everything that we do. If this patient gets an infection that holds up in that joint, you're talking weeks and weeks and weeks of IV antibiotics. You might be looking at additional surgery to remove the joint. It's just a really, really bad situation. For VTE prophylaxis, you're looking at anticoagulants. Sometimes it's going to be sub-Q heparin, sub-Q Lovenox, but with joint replacements, they usually have to stay on something for several weeks, even a couple months afterwards. So oftentimes you'll see aspirin therapy. You might see things like Xarelto. You might even see things like warfarin or Coumadin. They will have TEDs and SCDs on the unaffected leg. Okay. In a couple days, we'll also be putting them on the affected leg, and they should be encouraged to do ankle flexes and circles, okay, every hour. Pain management, again, I had mentioned the nerve block. Typically what they will do with these patients is they will be on a acetaminophen and a low-level opioid, usually like Ultram, every 6 hours around the clock. And the whole idea is to provide them with around-the-clock pain control, and then they can use some of your stronger opioids, usually oxycodone, for breakthrough pain in between. It's also not uncommon for these patients to initially come back from surgery with a PCA pump, a patient-controlled analgesia. Typically, that is discontinued sometime post-op day 1. Ice cold therapy is also important. We use ice to around the incisions, above the incision, below the incision, and to each of the sides, typically 4 times a day. Pulmonary hygiene, your coughing, your deep breathing, your incentive spirometry, very, very important to prevent atelectasis and pneumonia. Now, specifically for arthroplasty for the knee, everything we talked about before is going to apply to any arthroplasty. For the knee, again, CPM is prescribed. They often have a knee immobilizer for the first 24 hours or so, and they are typically weight bearing as tolerated. You want to avoid elevating the legs or elevating the knee. You know how the bed, you can raise the head, raise the foot. You want to watch raising the foot because that's actually right underneath the knee. You also do not want to have pillows right behind the knee. Where you want the pillow is under the lower calf and foot because you want to slightly extend the knee joint. That's very important to prevent flexion contracture. You also want to use a towel roll to elevate the ankle heels off the bed. And keep in mind that they will not be able to kneel or do deep knee bends, and that's pretty much indefinitely. On the hip side, if we're talking about a hip arthroplasty, typically they're going to be positioned supine and their head will be slightly elevated. The affected leg needs to be in the neutral position. It's very, very important that they don't cross that leg past the midline. Okay, so an abduction pillow is typically used while they're in bed and when they're turning to prevent that. If you cross the midline, you can have dislocation of the joint prosthesis. We don't want to turn them on the operative side. Typically, they'll be weight bearing as tolerated, but that will depend on the actual technique of the surgery. They will use assistive devices, and they need to use adaptive equipment, okay, because they cannot flex the hip greater than 90 degrees, which means they cannot bend over, they cannot cross their legs, and they should not be internally rotating their toes. So that adaptive equipment, the raised toilet seat, is going to be very important. Grab bars, shower chairs, dressing sticks, because they're not going to be able to bend over to put their socks and shoes on. Long-handled shoehorn. So physical therapy works with mobility. Occupational therapy will work with their ability to do ADLs because they're not going to be able to do these things until everything heals. And they really should avoid any type of low chairs.